That fine? Tanu, are you ready?
Yes, sir.
Okay, we start when Zoom says recording in progress.
Namaste and greetings. I, Tanu Paliwal, researcher at IMPRI, Impact and Policy Research Institute, प्रभाव एवं नीति अनुसंधान संस्थान नई दिल्ली extend my warmest welcome to you all to IMPRI Web Policy Talk. We are gathered today for a panel discussion on population, health, and Union Budget 2025-26 as a part of IMPRI's sixth annual series of thematic deliberations and analysis of Union Budget 2025-26. This discussion is organized by the Center for Human Dignity and Development, IMPRI, Impact and Policy Research Institute, New Delhi, as a part of IMPRI Web Policy Talk series. I welcome all of you to this enlightening deliberation and thank you for tuning into this discussion. Now, let me introduce the esteemed gathering. Our chair for the session is Dr. Manorama Bakshi ji, Director and Head of Healthcare and Advocacy, Consocia Advisory, Founder and Director, Trilok Raj Foundation, TRF, Visiting Senior Fellow, IMPRI. We welcome you, ma'am. The distinguished panelists for the sessions are Dr. Urvashi Prasad ji, ex-director, Office of Vice Chairman, Niti Aayog; Dr. Poonam Mutreja ji, Executive Director of the Population Foundation of India; Dr. M.R. Sitaram, Advisor and Member, Swami Vivekanand Youth Movement, Senior Orthopedic Consultant, Vivekanand Memorial Hospital. Dr. K.S. Uplabdh Goyal, Associate Fellow, Health Initiative Observer Research Foundation. I welcome all of you. Can we have the slides, please? Yes. So, sorry, just a minute. Okay. So today I'll be presenting on the critical intersections between population, health, and the Union Budget 2025-26. As we examine the key trends, budget allocations, and policy reforms, we also highlight the certain loopholes that need urgent attention to ensure effective governance and development. Let us begin. So, India's population is projected to reach 1.43 billion by 2025, continuing its rapid growth trajectory. Urbanization is accelerating, with 40% of the population expected to reside in cities by 2030. While this presents economic opportunities, it also raises challenges related to housing, infrastructure, and employment. Moreover, India's aging population is increasing, with over 10.5% of people aged 60 and above by 2025. This will place additional pressure on healthcare services and pension schemes. To fully leverage a demographic dividend, the government must focus on skill development programs to enhance employability among youth. So, now coming to the loopholes and challenges, the unbalanced urban-rural development, which is growth is concentrated in metro cities, leaving rural areas behind, limited overpopulation policies. So there's no significant measure to curb population growth, which has been introduced till now. Also, there's slow digital adoption. Many regions lack proper demographic data tracking affecting policy making. Next slide, please. So here you can see, the figures which I have projected. Next slide. So the Union Budget 2025-26 has emphasized healthcare expansion and innovation. The Ayushman Bharat scheme is set to receive rupees 85,000 crore, aiming to extend insurance coverage to millions more. Additionally, the Digital Health Mission will get rupees 12,000 crore to enhance telemedicine electronic health records. These steps indicate a commitment to strengthening India's healthcare infrastructure. Investments in medical research and vaccine development is also increasing with rupees 20,000 crore allocated to research and development R&D. However, mental health remains underfunded, receiving only rupees 5,500 crore despite rising cases of anxiety and depression. Coming to the loopholes and challenges, rural healthcare remains underfunded. Most investments favor urban centers. There's also a problem of doctor shortages. So India faces a severe shortage of medical professionals, especially in tier 2 and tier 3 cities. Mental health needs more focus. The current budget for mental health is inadequate given the increasing demand. Can we have the next slide? So these are the allocations. Next slide. So, one of the key lessons from the COVID-19 pandemic is the need for a robust disease surveillance system. The 2025-26 budget allocates rupees 18,000 crore for pandemic preparedness, focusing on vaccine research, response planning, and medical infrastructure upgrades. Additionally, rupees 10,000 crore has been allocated for the National Disease Control Program, which will track and combat infectious diseases. Another crucial area is maternal and child healthcare, which is receiving rupees 15,000 crore to improve nutrition programs and maternity support. However, the challenges remain. So the loopholes are slow response to new health threats, bureaucratic delays hinder quick action, vaccine research faces delays, production challenges and approval bottlenecks remain. Rural clinics lack proper funding and equipment. Many remote areas still do not have basic healthcare facilities. Next slide. So here you can see the data. Next slide. So the government aims to increase healthcare spending to 2.5% of the GDP, which is a positive step. Public-private partnerships are being promoted to build new hospitals and improve the access to healthcare. Insurance schemes like universal health coverage are also being strengthened. However, some major financial challenges persist. Healthcare spending, although increasing, is still below the global average. Additionally, transparency in PPPP project remain a concern, and some marginalized communities are still excluded from the government healthcare schemes. So the loopholes and challenges are healthcare spending still below global average. India lags behind developed nations in per capita health expenditure. PPP efficiency issues. Some partnerships suffer from corruption and inefficiency. Exclusion of certain populations. Many vulnerable groups do not receive adequate healthcare benefits. Can we have the next slide? So here you can see the budget expenditure breakdown. Next slide. This is the data which I just now said. Next slide. The grand total of the budget. Okay. So the government's focus on strengthening healthcare infrastructure is evident in the increased allocation to centrally sponsored schemes. The National Ayush Mission has received a boost with funding rising to rupees 1,275 crore for 2025 and 26, reinforcing India's commitment to integrating traditional medicine with modern healthcare. Additionally, transfers to states and union territories under centrally sponsored health initiatives have seen a significant rise, reaching rupees 3,992.90 crore. This indicates a strategic push towards decentralizing healthcare and ensuring that state-level health programs receive adequate financial backing for effective implementation. Next slide, please. This is the data. Okay. So in conclusion, while the Union Budget 2025-26 has made significant strides in addressing healthcare and demographic challenges, certain gaps remain. Investments in public health, pandemic preparedness, and insurance schemes are commendable. However, the rural healthcare, mental health, and transparency in partnerships need urgent attention. Going forward, the government must work on bridging these gaps to ensure equitable and sustainable development for all. Thank you. Now, it's my privilege and an honor to invite Dr. Manorama Bakshi ji to start the program with the opening chair remark. Welcome you, ma'am.
Thank you, Tanu. Thank you so much. To begin with, first of all, a very warm welcome to all the esteemed panelists and our virtual audience. Healthcare remains central to India's growth story, not just as policy priority, but as a pillar of economic and social resilience. The National Health Policy 2017 envisaged universal health coverage, and over the years, we have seen and witnessed the investment, especially post COVID-19, driving AI-led diagnostics, genomics, precision medicine, and digital health integration. With artificial intelligence and ML revolutionizing disease surveillance genomics, unlocking new frontiers in the personalized medicine, and production-linked incentives schemes fueling the medical device innovation, India is positioned to become a global healthcare powerhouse. However, while India is making strides in health innovation, the scale and sustainability of these advancements, strides in increased budget, incremental allocations, robust policy execution, and strategic investment in digital health and AI integration. Looking at Ayushman Arogya Mandir website, India has operationalized 175,000 health and wellness centers, upgrading sub-centers and PSCs to deliver comprehensive primary health care that includes maternal and child health, NCD screening, essential drugs, and diagnostics. Each health and wellness center, as per the Arogya Mandir website, it caters to 358 outpatients per month with 128 NCD patients and covering 31% of outpatient care needs. However, with India's population projected to reach 1.5 billion by 2030, and with the rising urbanization and aging demographics, as just now we saw in the presentation, are these centers equipped to handle the escalating burden of NCDs? So is the budget 25-26 a step forward? Is it enough? The Union Budget 25-26 has increased. If we include Ayushman Bharat PMJAY expenditure also, then it has increased by incremental 11%, allocating 1,03,851 crores versus 94,671 crores last year. And I'm giving this figure including Ayushman Bharat PMJAY. Otherwise, it is around 95,000 crores and not much, around 9 to 9.1% increase. However, healthcare now accounts for only around 2% of the total budget, reflecting a decline trend from the previous years, when allocations consistently remained above 2%, except during COVID-19. Recognizing the need of more doctors and specialists, this budget announced 10,000 new medical seats, contributing towards long-term vision of universal health coverage and national health policy. Long-term vision of 75,000 additional seats are there to be again taken up in the next 5 years. Over the past decade, 1.1 lakh undergraduates and postgraduate seats have been added. That is around 130% increase. However, despite expectations, there were no major announcements on the public-private partnerships in the medical education, alternating a financing mechanism for the students or structured faculty development, medical value travel, and health innovation. The Heal in India program was acknowledged in the budget with an allocation of 20,000 crore, aimed to streamline visa process for international patients and expanding private sector collaborations. However, dedicated medical tourism zones with tax incentives, SEZ, are still missing, leaving room for future policy interventions. The pharmaceutical and medtech industries saw mixed response in the budget. The government exempted 36 life-saving drugs from the basic customs duty and introduced a new patient assistance programs, yet critical industry demands such as higher R&D incentives, regulatory reforms, and export promotion support remain unfulfilled. The digital health question, where is the vision? While India is making significant advancement in AI-driven healthcare, the clarity on e-health initiatives remains limited. The Ayushman Digital Mission is a game changer for India to truly harness the potential of AI, ML, and digital health. And more structured national roadmap is essential. The potential is vast. AI can transform diagnostics, genomics, and enable personalized medicine, and medtech innovation can drive affordability, but only if backed by strategic funding, clear regulations, and seamless integration with the public health infrastructure. The key areas of discussion today with our esteemed panel will be: is budget educate 11% growth enough, given declining share of the total spending? Cancer care and drug affordability. Does the customs duty exemption on 36 drugs translate into better patient outcomes? Medical education and infrastructure. Will the quantity compromise quality? AI and ML and digital health. Can technology bridge India's healthcare divide? Public-private partnership and medical value. How do we unlock India's potential as a global medical hub? With a distinguished panel bringing expertise across health policy, healthcare delivery, financing, consultancy, and innovations, and reproductive and child health, including the family planning, we are here to set for insightful discussion. To begin with, I request Dr. Urvashi Prasad, ex-director, NITI Aayog. Madam, is the 11% healthcare allocation adequate given India's global ranking and the Viksit Bharat vision? Over to you, ma'am.
Thank you, Manorama ji, for also, giving a very nice summary upfront. So I, wear three different hats. One is, of course, I'm a public health professional. Secondly, as you mentioned, I'm a policy professional. But I think one of the most important hats is that I'm myself a patient of a very rare form of lung cancer. And I think that gives me a very unique perspective to, all these discussions. So I think first I'll just talk about the allocation because that's what you want me to address first. I don't believe it is adequate. I haven't believed it is adequate for many years now. We are a country of 1.4 billion people, as was shown on one of the slides. To be investing this amount in health is just grossly inadequate. I've heard that argument countless times that it's not about the quantum of money, it's about how you use that money. And sure enough, that's true. But quantum is also important, and if you put in so little, then it is always going to be problematic. So I think that, and actually, if you look at the numbers, if you remove that COVID blip, when we actually had a big, jump suddenly in one of the years because we had COVID vaccination and we had some 35,000 crores budgeted for that. But if you remove, some of those blips that we've had, and adjust for inflation, then actually you're not left with too much, of an increase. And remember that we start from a very low base. We've always underinvested in health and in public health more so. So I think, for public health professionals like me, and even, when I was working in the Niti Aayog, I used to put it across as forcefully as this, because I think if people like us don't speak, then I don't know who will. And I don't know when that realization will dawn on us. As you said, that healthcare is one of the most critical pillars. But I think we still see it as an expense. We still see it as an expenditure. We don't see it as an investment. And I think it needs a lot more voices. Like I keep trying to raise mine. I think you have to multiply that by a million, or many more times, for the real decision makers to see it as not an expenditure, but as an investment. Because if you're talking of Viksit Bharat, you're talking of your workforce, If your workforce is not healthy, it is not productive, then I don't know how you can build a developed economy. So it is not just an expense, it is actually an investment for your future, for your economy, to become a developed nation, to become a happy, productive society. So in that respect, yes, India, it's predominantly a state subject, health. So states have a big role to play as well. I wouldn't take away from the onus on them, but I still feel that the center needs to do a lot more. Of course, we'll come to the other semantics later, and the other aspects of the budget and the implementation issues. But I think even in terms of quantum of funding, we surely need to do much better for a sector which is so critical for the country and for the economy.
Thank you so much. Thanks. I take your words the way you said the healthcare we take it as an expenditure and not as an investment. And I also agree with you when you said we need to ensure a roadmap for sustained investment beyond incremental annual increases. Now, I would like to ask you a bit of like the budget has said about having 200 daycare centers, cancer care centers. And do you think that these centers will improve, the actual, the care for these patients and improve the accessibility? And what are the challenges if we look at India's, reaching the last mile? What are these challenges? And what does the customs duty, exemption of customs duty, if you can decode it, like 36 life-saving drugs, making cancer treatment truly affordable? If you can decode these things for us, it would be really nice. Over to you, Dr.
Okay,
Prasad.
yeah, thank you. So, I think on the cancer care centers, again, I think that the devil lies in the details of the implementation. Like most things, when we announce it, of course, in theory, nobody can disagree with it. That we need it, at the district level, because most people, like was also said, I think Arjun said it, that most people are still traveling to a Delhi or a Mumbai, and so having that cancer care closer to where people are certainly will be more convenient, more affordable for them, and could lead to even better outcomes, because a lot of times the distance you have to travel is quite a deterrent to going for your regular monitoring, etc. So I think in theory there is no debate that it would, in my mind, that it's a great idea, but the execution is everything. And we are talking at the district level. We need to see, do we have enough qualified personnel? If not, what is the roadmap for training and putting those personnel there? What is going to be the supply chain for the medications? What are the kind of services we're going to provide there? Because cancer care, so a few years ago we had an announcement of dialysis similarly at the district hospitals. Dialysis is still one intervention. Cancer care can be a lot of things. So what are we going to provide there? Is it just the basic chemotherapy? Are we going to do more things also? What is it going to entail? And what will it take to really implement it well? I think that is where the question is in my mind. Because like you said, you read out the figures on the Ayushman Arogya Mandirs. Now I've actually done a study on these, when I was at Niti Aayog, and that's what we found, that the gap between what is stated on the guidelines and the numbers on paper and what we see on the ground, in many places that gap is still vast. And even in terms of screenings, right? So on the website we might say, okay, we screened so many people, but it doesn't really tell you how often did we screen them, how systematic was it, did we refer those people? Suppose I screened and I found a certain number of people needed referral. What did I do with that? Did I follow up with those people? So I think those are the real questions, right? I think the numbers look great, and in India we can often run into showing that we've done lakhs of this and lakhs of that, but the actual quality, as somebody who always likes to go on the ground and see, okay, what's happening here, and there's always a lot of mismatch in many areas. So I think that is a concern with the cancer centers. But I think on the customs duty, Again, we need to see, these drugs individually that are being talked about here, and to what extent their costs are coming down. Because some of these drugs truly are out of reach, for majority of India's population. Even for someone like me, I'm on an oral targeted therapy by Pfizer, and it is so expensive. So even if you cut the cost of it by a certain percentage, it's still, it is very expensive. You also have GST, you have other things that you have to look at. So we need to see which are these drugs, how do patients access these. Patient access programs often don't work for a lot of poor patients, because I get poor patients coming to me almost every day that, the patient assistance programs are not working for us. So again, nobody can dispute the intent behind, doing some of these things, but everything will come down to the details and the execution. And I think that is, the question I have in my mind, because cancer care, if I'll just quickly, conclude on these questions, it's a whole package. You can't just look at it as bits and pieces. It's everything from prevention, screening, detection, diagnosis, treatment, and then rehabilitation. We don't even get to that part. So it's a whole, and I've been advocating that we need a comprehensive cancer care program, instead of kind of fitting it into different schemes and saying, okay, there's a little bit in Ayushman, there's a little bit here, there's a little bit there. We need a much more comprehensive and holistic approach, equally to tackle the financial issue. And that is why I'm saying that just the customs duty coming down on a drug, it might still mean that there's still a lot of burden, because the treatment is a much broader thing and there's many more elements to it. So yeah, those are my thoughts on that.
Thank you so much. Thanks, Urvashi, for explaining it to us in a very nice way. Definitely, affordability extends beyond the tax exemptions. There are so many things beyond tax exemptions, as you rightly said. Now, something is there like what I have been hearing, being a public health professional, a lot of like about the precision medicines, about the AI and ML coming into, and genomics, next generation sequencing, coming into the, in the field of cancer drugs. So, and I would also like to know a bit about, since government has said now up to PhD level and Ayushman Mandirs, they will be supported with, Bharat Net, and they will have the Bharat Net facilities and all this. What does it mean as AI and ML in public health, like reaching up to the, PhD level, CST level at the grassroots levels? What does it mean, and what does it translate into?
Is that question for me?
Yes.
Okay.
You can, because
Okay,
you're a
I didn't
policy
realize we
person,
were
so
still on me. I thought you were done hearing my voice, so
you
I
have
went
heard the
on
question?
mute.
You have heard the question or no?
No, I've heard it. I've heard
Yeah.
it. So, yeah. So I think again, AI, ML, digital, a lot of these things, the blueprint, etc. I was also involved with at NITI. We were making the national AI strategy and various things like that. The challenge I see in that is still the integration across the health system. Yes, we've been talking about it a lot, but seamlessly integrating it so that it becomes a real tangible benefit for every patient. Of course, we have a lot of work to do on that front. That is an element of the technology, of course, but it is also an element of skilling. It's also an element of the HR having the capacity, also having the inclination to use a lot of this technology, because sometimes the workers at the ground level, if you just give them something, sometimes they feel that is this really beneficial, is this helping me in my work, or am I just doing it because I have to do it, or because I have to report to somebody, or is it really easing my workload and improving my efficiency? So I think what is in it for each person in the implementation chain also needs to be clearer, because then I think adoption is also faster. But of course, along with that, skilling, capacity, those are all issues. And I think on AI, ML, etc., like I've been saying, that we need to pick up. We've had smaller pilots. Different people have done. Some startups are doing very innovative work. But I think we need to scale, and in India, that is the challenge, right? Everything we have to scale to really see that benefit. And I think for that, if we can pick up 2, 3 missions, that is what I have been suggesting, like rare diseases, like the kind of disease I have where every individual doctor has very little information because they've only seen a few patients in their whole lifetime. But if I can pool in the information from all the doctors in India and across the globe, apply technology to it, get some meaningful insights, then as a patient, maybe my future treatment could be better informed. And then I will really be able to see, okay, this is how AI, really helped me or my treatment. So I think in mission mode, we need different stakeholders to just pick up, 2, 3 of these things. I'm just giving rare diseases as an example. It could be something else. But really apply, show how technology is being applied and how we are getting tangible benefits of that at scale. So that's where I think we need to kind of, move with this whole discussion, because we've had these words and terminologies now around for a while, but we need to make it very real, for the patient there, that this is the benefit for me, and also for the clinician, what is the benefit for me. I think that also has to become much more tangible across the health system.
Thank you so much. Thanks, Dr. Urvashi, for addressing this very pertinent question. Even though I agree with you, AI can be a game changer, but adoption and actually the competency and adoption remains fragmented. Agree with you. Absolutely agree with you. Now I am requesting Dr. Uplabd. Dr. Uplabd, am I audible for you?
Yes, go ahead.
Yeah, Dr. Uplabd, I will ask you a couple of questions, but into two, sessions. Like first, if you can speak about the latest increase, what the government has said, 10,000 new medical seats and infrastructural development they have been talking about. And second is, will this really, the infrastructural expansion, enable overburdened hospital, and in what way they will enable them, and in what way they will make them more efficient? If you can throw some light on these two things, and later I will come to next question. Yeah.
Sure. Thank you for the question, Dr. Manorama. On the surface, the announcement of 10,000 new medical seats and the broader goal of adding 75,000 sounds like an excellent step. After all, India has long struggled with the shortage of doctors, and this expansion should, in theory, help. But the real question is, do we have the infrastructure and the faculty to sustain such a quality education, or are we simply just increasing quantity? First, let's talk about faculty. See, medical colleges don't just need buildings and classrooms. They need qualified teachers, experienced doctors, and robust clinical exposure. The economic survey that just recently came out highlighted that the number of medical colleges have doubled in the last decade, from around 400 or so to currently around 780. But we're not producing medical educators at the same rate. Faculty shortages persist, and this has had real consequences. In some colleges, we've seen ghost faculty, doctors who are on paper but are not actually teaching, just to meet accreditation standards. And then there's the elephant in the room, which is salaries. A fresh MBBS graduate in India earns around 5 lakh rupees per annum, while senior doctors make between 12 and 18 lakhs. So we can compare this with the earning potential abroad. Many Indian doctors migrate simply because the remuneration and working conditions are far better. The economic survey tells us that India already has over 19,000 doctors working in OECD countries, and around 3,000 migrated just 2 years ago. This means that we are training doctors, but many of them are becoming part of the global workforce rather than strengthening our own health system. Regional disparity is another major issue. The data shows that 51% of undergraduate or UG and 49% of PG seats are concentrated in South India, leaving vast parts of the country underserved. Yet this budget has made no major announcements on like public-private partnerships to set up medical colleges in Tier 2 and Tier 3 cities where they are needed the most. And let's not forget the cost of medical education. For nearly half of all MBBS seats in India, which is around 48%, are in private colleges, where the fees range from around 60 lakhs to 1 crore rupees. That's why thousands of Indian students go abroad to study in countries like China, Russia, and Ukraine. But when they return, they face hurdles. Many fail the foreign medical graduate exam, and some, like those stuck in Ukraine during the war, couldn't even complete their degrees at all. So what would be the way forward? We need investment not just in increasing seats, but in faculty training, structured incentives, and most importantly, creating a structured pool of medical educators and faculties to sustain the expansion. We need alternative financing mechanisms like subsidized loans and interest subventions to reduce the cost burden on the students. And we need strategic PPPs to expand medical colleges in underserved regions, ensuring that we don't just concentrate medical education in a handful of states. If you're serious about expanding medical education, we need to move beyond numbers and focus on sustainability. Because what's the point of producing more doctors if they don't stay, don't have the proper training, or end up in cities where they are least needed? Regarding healthcare infrastructure expansion, which should in theory lead to decentralization, that is bringing care closer to the people. But is that really happening? Or are we reinforcing a system that directs more patients to an already burdened metro or tertiary hospital? So the National Health Policy, NHP, or National Health Policy of 2017, that envisioned that two-thirds of the health budget, it should go towards primary healthcare and ensuring that preventative services, early intervention, and community-based care is there. However, the proportion has remained stuck at around 40%, with the share of the NHM declining over the last 5 years. Instead, the budgetary priorities have shifted towards tertiary care investments, such as the presentation that was given in the starting of this webinar, where AIMS expansion and high-end specialty hospitals were the focus. Looking at the numbers, we can see that the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana received around 9,400 crores, which is a 29% increase from last year. And I think this is largely due to its expansion to cover all the citizens aged 70 years and above. Also, the Pradhan Mantri Ayushman Bharat Health Infrastructure Mission, or the PM BHIM, got 4,200 crores. That is around a 40% markup from last year. Now, while these are important investments, let's ask, where is the primary healthcare push? Taking the example of vaccination programs, despite being the most cost-effective public health intervention, they received little attention in the budget. The HPV vaccination program, critical for preventing cervical cancer, which has been getting quite some attention recently from the government with various initiatives, didn't get a mention in this budget, which I found surprising. Let's also talk about the impact on hospitals. While the budget rightly expands tertiary care infrastructure without strengthening PHCs, CHCs, more patients will continue flooding the high-end facilities. Imagine someone in a rural area with an easily treatable condition, say diabetes or hypertension, who lacks access to regular care. Over time, that person's condition worsens, leading to complications that require expensive tertiary care. This is the cycle that we need to break. So how can we course correct? We can reverse this funding trend that we're seeing, which is increase the allocations for the National Health Mission and primary care to around 60% instead of focusing predominantly on tertiary care. We can expand the preventive healthcare like vaccination programs, screenings, and early interventions, which should be our key priorities. And lastly, we can strengthen the last mile, which is ensure that PHCs and CHCs are not just buildings, but fully functional facilities with trained staff and digital connectivity. From the rural health statistics, which has now been rebranded, I think a lot of CHCs and PHCs do not even have electric connections and struggle with electric connectivity. At the end of the day, a resilient health system is one where the hospitals are not the first to stop or care, but the last resort. If we don't address these imbalances, we're not decentralizing our healthcare system, we're just expanding a system that is already overstretched. Regarding PPP or public-private partnership, a lot of people often see it as the magic bullet for healthcare gaps. But here's this thing: they're not just about bringing in private investment. They're about designing partnerships that actually serve the public interest rather than just increasing corporate footprint in the healthcare system. So how do we get it right? So India has successfully leveraged PPPs in diagnostics where private labs handle high-end testing while the government hospital focus on patient care. Telemedicine services in the rural area, I think, will also be benefited from private expertise, particularly with the budget mentioning a recent broadband push, as you rightly mentioned, Dr. Manorama, under the BharatNet program. And of course, we've seen PPP-driven vaccine manufacturing, which was very crucial during the COVID-19 era. But where are the missed opportunities? I feel medical education is one where the budget acknowledges the need for more doctors, but there are no major announcement on PPPs to expand medical colleges. I also feel that infrastructure takes time to build, and I think we'll have to accommodate for that. PPPs can also help develop district hospitals and specialty care centers, reducing the overburdening on AIMS and other tertiary facilities. I think we should be focusing on the primary care provider or the physician in this instance. See, from the recent national health accounts, we know that the out-of-pocket expenditure is around 40%. It has declined, but it still remains high. Yet I think the budget ignored tax reductions around health insurance premiums. Like bringing private insurers into strategic partnerships could expand the missing middle's access to affordable coverage, particularly for people who are not poor, neither poor enough for government schemes or not rich enough for private insurance. So how can we make PPPs work? Like first, we must incentivize affordability first, and second, accessibility, and not just high-end services in urban centers. Second, I think with the advent of AI and big data, I think we can improve efficiency, but data privacy and ethical concerns must be addressed if we are implementing any health tech solutions. And at the end of the day, PPP should bridge public sector limitations and not just replace them. Yes, over to you, Dr. Manorama.
Thank you so much, Dr. Gopal. You have raised very pertinent and critical point of saying that expanding medical seats is not significant achievement unless until we address the issue of retention and the quality, and also addressing the PPP about the medical doctors, like unless until we have the structured models so that and have the PPPs for the training the doctors and having more doctors on board. So now I'd request you, Dr. Uplabh, if you can talk a bit about the medical value tourism, what the government has said, and almost 20,000 crore allocation is towards the medical value tourism. Throw a bit of light on that. That would be great.
See, India has been like long known for its potential in medical value tourism, which is a term, or MVT it's popularly called. And I think India has a potential that we can offer the world like very value class healthcare services at very competitive prices. However, in recent years, we've been losing ground to countries like the Turkey and the UAE, particularly Dubai, which are leveraging their strategic location and aggressive investments in healthcare infrastructure to attract more international patients. The global medical market, tourism market, is experiencing rapid growth, and some projections have put it around 25% CAGR growth, like from 23 till the next decade, 2030. Countries like Turkey have positioned themselves as the transit hub for European and Middle Eastern patients, while Dubai has set ambitious targets aiming to attract over 500,000 medical tourists annually. These nations are creating seamless high-end ecosystems. They have integrated accreditation, they have visa facilities, they have government-backed infrastructure development. Meanwhile, India, despite us having a cost advantage, we're still struggling with like an inconsistent MVT framework. So I think the first thing to look at would be accreditation or building trust in the Indian healthcare system. So one of the biggest factors influencing a foreign patient's decision is trust. Patients want to know that they're receiving globally recognized high quality care, while India has NABH and only a fraction of hospitals serving those serve international patients have the JCI, or the Joint Commission International Accreditation, which is a global gold standard. So a PPP model could encourage more hospitals, especially in the tier 2 cities, to obtain dual accreditation, which is NABH and JCI, and this can position India as a quality first destination. Without international accreditation parity, high-value patients from the Europe, the US, and the Middle East may continue opting at the locations that are between them and us than going for us, because these countries have a better and more regulated system. Second, I would say would be an ease of travel and simplifying the visa process. So medical visas still remain a bureaucratic maze for foreign patients. So I think a good initiative, that is the Heal in India initiative, is a good step. But to truly streamline the tourism sector, we need faster visa approvals through a single window process, a digital first process, and special medical e-visas, which can have multi-entry permissions so that patients can return for follow-ups. Then we can have companion-friendly visas, which allow the family members to stay longer without constant extensions. If we can digitize visa approvals just like we did with passports, we could dramatically reduce wait times and make India accessible. Right now, Dubai's DHA, the Dubai Health Authority, facilitates visa approvals within 48 hours for medical tourists, a benchmark which I think our country should aim for. Regulations, I would say, as one challenge is pricing transparency. So treatment costs can vary widely between hospitals. Creating a standardized cost framework for like common medical procedures can enhance the confidence of foreign patients in our system. Additionally, there should be legal protections for international patients, such as like a dedicated grievance redressal mechanism, which could make India a more safer bet and like a more predictable destination for medical care. So Dubai, for example, has set up a dedicated medical tourism council that oversees patients' rights, medical malpractice, and price standardization. So India needs a similar regulatory body to oversee MVT governance. And I think from the PPP side, instead of scattered efforts across different cities, India should develop specialized medical tourism zones modeled after the like SEZs that we have with tax breaks in cities such as Chennai, Mumbai, Delhi, and Hyderabad. These zones could, I think, I think these zones already have world-class hospitals and wellness resorts and rehab centers into a single destination, like the Dubai Healthcare City, which has become a model for medical tourism. Additionally, I think India should tie up with global insurance providers that can ensure that the international patients that there are, they can seamlessly use their coverage in Indian hospitals. This would make treatments in India not just affordable, but also financially accessible. So I think medical tourism is not just about healthcare. It is, I think, about the entire experience. So patients want easy travel, a world-class care, and a seamless recovery process. So I think if we can get the accreditation, the visas, and the regulations right, we can, I don't think, just compete with Turkey and Dubai, but I think we can set a global benchmark for medical value tourism. And I think in for this, uh, PPPs are essential to expanding India's medical tourism hub, not just in terms of infrastructure, but also creating a seamless and culturally familiar experience for international patients. So right now, India attracts medical tourists primarily for affordability, but to truly lead the global market, we need integrated systems, something I think that the PPPs can help build. First, like I talked about medical tourism zone in key cities catering to regional preferences. So I think a good example would be Chennai, which has a long-standing history of attracting patients from Sri Lanka, offering specialized care in oncology, cardiology, organ transplants. Kolkata also has naturally emerged as a hub for Bangladeshi patients, given its geographical proximity and shared linguistic and cultural ties. Similarly, Kerala, especially Kochi, has positioned itself as a holistic healthcare destination. And I think it can blend modern medicine with the whole wellness and tourism space, Ayurveda, etc. The recent Health in India initiative, which was highlighted in the union budget, I think is expected to further boost the medical tourism sector, especially for Kerala. This state already has a strong foundation in healthcare infrastructure, cutting medical technology and skilled professionals. I think industry leaders would have welcomed this initiative, noting that the simplified visa norms could be a game changer. And secondly, PPPs can play a crucial role in international insurance networks integration. Many foreign patients, like face difficulties because their insurance is not recognized in India. So I think that is something that we can offer direct billing agreements with global insurers. And like finally, PPPs can like ensure like a complete overall patient experience by giving hospitality and tourism services. So I think a well-structured model could create government-backed concierge services like dedicated medical tourism visa centers, like a multilingual patient support programs, elements that have been successfully implemented in countries like Thailand and the UAE. So if done right, PPPs won't just help India attract more medical tourists, but also create a thriving ecosystem where global patients feel at home. Like with the right policies, I think India can become just a cost-effective alternative to becoming the world's most sought after medical tourism destination. Over to you, Dr. Manorama.
Thank you, Dr. Gopal. Thank you so much. I completely agree with you. Unless and until there is global trust in healthcare, and that is built on high quality care, seamless patient experience that goes as a word of mouth across, and international recognized accreditations, as you said, JCI, that can definitely make India a medical tourist destination. And later on, I'll be coming and summing up. You have raised some of the very pertinent points. Now, I request Dr. Poonam Mutreja, Executive Director, Population Foundation of India. Dr. Poonam, again, I'm putting you questions into slots. First, I would like you to talk a bit about women's health and family planning. Does the budget address the maternal and adolescent and RMNCHA adequately? And is the budget educate about what we call about the comprehensive care? So I want you to throw some light on that, and later on I will come about the fertility, TFR, and other questions. But first, if you can throw some light on, does the budget address adequately on RMNCHA family planning? Over to you, Dr. Poonam. Am I audible?
Poonam ma'am, can you please unmute yourself?
Can you hear me now?
Yes, ma'am. Yes, ma'am.
Thank you so much, Dr. Bakshi, for this opportunity. I should have written to you, but I do want to say I'm not a doctor. I could be counted as a quack. Allow me to comment overall on it's not just the maternal health and the family planning and child health budget, but on the whole, I will say that I continue to be disappointed that India's health expenditure, which was mentioned earlier, is less than 1.5, it's close to 1.3. And in the presentation that was made, there is a hope based on the family health policy that India will reach 2.5, but that's a dream we've been living in the previous government and the current government. So I want to say that overall, if you don't invest in health and the budget does not increase substantially, we will have only incremental growths, incremental investments in health. While the numbers increase everywhere, we don't factor that in. We neither factor in the inflation. So the budgets are overall inadequate. But as far as maternal health, women's health, and maternal health is concerned, 50%, as we know, of India's population is in the reproductive age group, and every fifth person is an adolescent between the age 10 and 19, as per the census 2011. This makes it important, very important, to invest in maternal and reproductive health, to harness also the demographic as well as gender dividends. So while India has made significant progress in maternal mortality, which has declined from 130 per 100,000 live births to in 2014-16 to 97 in 2018-20. Infant mortality from 40 per 1,000 people live births in 2013, we have come down to 28. Access to maternal and reproductive health services remain uneven. It depends on where you live, which income quintile you're in, and definitely tribals and tribal women and scheduled castes, scheduled tribes still are at a disadvantage, and they continue to be at a disadvantage. And nearly 57% in a country where 57% of women aged 15 to 49 are anemic, and 24 million, which is 9.4 currently married women in this age group, have an unmet need for family planning, as per the National Family Health Survey 5. And despite these challenges, budgetary allocations for maternal and reproductive health remain woefully inadequate. The NHM budget has increased by only 3.4%, which is 36 crores. From 36 crores, it's gone to 37.2 crores. Family planning under NHM increased by 7.7%, but family welfare schemes under central expenditure saw a negligible 0.2% rise, which is 619 crores to 620 crores. Given the recent introduction of also, if you look at new contraceptives that the government has introduced, and happily so, after 30 years, we introduced new contraceptives. But if you look at injectables and implants, they've only been introduced in 10 states because we don't have the funding. The limited budget makes the nationwide expansion extremely challenging. You know, when you have a 10% unmet need for family planning in terms of numbers, it is huge for India. And to bring in a child who the parents can't feed, who the parents can't educate, the parents can't, get healthcare, proper healthcare, it is an absolutely unacceptable and shameful situation. And as far as family planning is concerned, the budget makes broad commitments to health infrastructure and expanding medical seats, which was talked about very, very ably by Dr. Utlap. And the budget, so the budget commitments to health infrastructure and expanding medical seats, but it lacks a vision for integrating family planning and reproductive health care into a universal coverage, health coverage. With NHM seeing only 3.4% increase, the scale of demand is not met, especially considering India's vast population at a reproductive age. India's population may be declining, but we're going to continue to grow. A comprehensive health system must embed reproductive health as a fundamental pillar, rather than treating it as a standalone issue, which we are also raising in other areas, including was very aptly raised on cancer. We can't have these standalone programs where a comprehensive health system is what we need without targeted investment. India's UHC aspirations will remain incomplete. And as far as maternal health and child health, as well as family planning goes, it is the major backbone of our primary health care. And we with women having 60% of the women having anemia, being anemic, and especially those at a reproductive age, India can save a lot of money by investing in family planning. It can meet reach the unmet need. And I am absolutely surprised, given the demographic data we have for India. We are focusing on the wrong things. We keep focusing on which religious community has more people. Instead, we should be focusing on where women need attention, where women need family planning services, where if we want to be a Viksit Bharat, we first have to invest in the health of our young people, our women. And the reason we need to invest is also and has an economic rationale. We keep talking about investing in, the budget 2025 rightly continues investments in economic growth, which must be complemented. But there needs to be a parallel focus on human development, ensuring that a skilled, healthy, and productive workforce supports India's vision for a Viksit Bharat in 1947. Without adequate investments in maternal child health, sexual reproductive health, and the elderly care, the issue of elderly came up. We are going to, by 2060, 20% of our population is going to be an aging population. India risks missing the opportunity to fully leverage the demographic dividend if we do not invest in their health well-being. Thank you.
Thank you so much. Thank you so much. You have so nicely put it, aptly put it. You spoke about the comprehensive healthcare. Despite the progress made in MMR, access still remains deeply unequal. What you mentioned, tribal communities, adolescents, and especially you spoke about the unmet need, and you also addressed the 50%, 57% of the women facing the anemia. And it's the anemia is a big, huge burden on India, and it has so many other, implications. And whenever we talk about the maternal mortality, almost 33% of women die because of their things associated with anemia. And you have rightly put it, like when you spoke about the significant investment, unless and until you talked about the demographic dividend, you spoke about the adolescents and you touched the our elderly population, which is going to be around 13%, like in a couple of years. So I think unless and until we have the comprehensive health care to the last mile, I think the PSC, comprehensive primary health care, and universalization, reaching the last mile, I think they go hand in hand. And thank you so much, Dr. Poonam. Poonamji, thank you so much. Now, I would like you to address like something that is actually, which you have, even though raised the topic, like we have to think about the woman and not about the religion and from which demography she comes. But still, I would like, because you are an expert on these issues, I would like to touch, if you can touch a bit about India's TFR is now at 2. Should the policy shift towards the reproductive health and elderly care, one which you have slightly addressed, but the recent comments as Tamil Nadu Chief Minister M.K. Stalin and Andhra Pradesh Chandrababu Naidu ji urged their populations to have more children due to declining birth rates in South. And now, since you have been involved into policy making and community interventions and talking about these issues, I would like if you can talk like how should the policymakers balance concerns of population decline in some of the regions while still addressing the issues of unmet need, contraceptive needs, which you rightly said, and gender equity in the family planning.
Yeah, thank you. So India is already on course for population stabilization with total fertility rate, as you said, at 2.0, which is below replacement level. Well, the UN projects India's population to peak at 1.69 billion, by 2063. Other estimates, like the University of Washington, estimate it could peak at 1.6 billion by 2048 and then begin to decline to 1.1 billion by 2100. Given the demographic transition, our focus should shift from population. We should not be thinking of population control. We should be thinking of population stabilization and meeting the unmet need. And we should, given the demographic transition, we should also focus on investing in human capital, particularly youth skilling, women's health, and elderly care. By 2050, as we both mentioned figures, India's elderly population will double to 20%, with the 80-plus population growing by nearly 280%. Right now, our elderly population is 10%. And as you said, it's going to be in the next few years, it's going to be close to 16% or 15%. To prepare for the shift, India needs a differential policy approach. Advanced demographic states should focus on elderly care, which is the southern states. And I'll come to the comments of the two chief ministers. And given that, so by 2050, India's elderly population we have to prepare for it. We cannot wait for 2050 to come. To prepare for this shift, as I said, a differential policy approach. and elderly care and integrating migrant workers. Migration is going to be a phenomena, especially from states like Bihar, UP, and Assam, and many other states, migration. So we may as well accept it as a reality and be prepared with integrating migrant workers, while lagging states must ensure universal access to reproductive health and education and skilling. But much more family planning services are needed in the north than the south. So we have to look at the differences in demographics as we develop strategies. For instance, we did a population policy for UP, and I can already see the impact. The policy was released only 3.5 years ago, but the impact, the way the UP population policy is being implemented, I see a very bright future for UP in terms of declining population. And but Bihar, which also we did a population policy, which is languishing because the government keeps changing. The political instability doesn't help health for sure. They haven't implemented a policy, and they need to strictly have a policy, clearly have a policy, and a robust healthcare system to support an aging population, including specialized geriatric care. Where have you seen geriatric care in India? I mean, Kerala has begun, just about begun, but in the rest of the country, we do not have, and with the influx of migrants, not just to south from north, but to cities. Delhi is a classic example. Parents are left alone. We need to take care of them. And now that nuclear families are on the increase, we absolutely need social security, geriatric care and security for the informal sector. Declining, I'll come to the, what happened in the southern states. So, global evidence shows that simply telling women to have more children doesn't work. Fertility decisions are influenced by education, economic opportunities, social context, and healthcare access. And frankly, for the two chief ministers to ask women to have more children, not just in India, I'm seeing this phenomena in Russia. Putin has asked women to leave the workforce and sit at home and have 8 children. And, this violates women's reproductive rights, women's and family decisions. This is like the government entering the bedroom. You cannot go in and say how many children a woman will have, especially if a woman or families have decided they're going to have 2 or less children, or families can't afford. Look at the food inflation. In India, 80% of the food expenditures is on the food basket. So when people cannot afford to have 2 children, to be asked, it also violates their economic rights, apart from reproductive rights. So instead of imposing expectations on women, policymakers must focus on empowering families. States with high fertility rates and targeted investments in education, healthcare, and skill development must enable young people to enter the workforce productively. Southern states and those with aging populations must, as I said earlier, strengthen geriatric care, social security, workforce participation of women, and for older adults. Rightly, the UN report, the UN population report has called it the silver dividend. And I think it's a very positive way, where we not only invest in geriatric healthcare and social security, but we create opportunities by upskilling, retired people at age 60 or 62 to be functioning members of society. We are talking about medical tourism, but if you look at the state of both the private sector and the public sector, patients don't know where to go. So can we not have an army, if I may use that word, of older people who are trained to help support the public health as well as in the private sector? They are hired and so on to just help patients navigate. It is a nightmare to be in a hospital, even for the empowered, privileged, better off like us. So there are many other ways than caregiving, caregiving of the elderly, caregiving of the for the young. This is an economy waiting to happen, and elderly can play a role in that. So policymakers must address also the issues of gender inequality, ensuring better access to education, employment, and not only social security for women, but also supporting women with childcare. Countries like Sweden, Norway have done very well compared to Russia, China, many other countries where they have an aging population and young people are not having children. You have to support women to have a balanced work and home life. We have to change the attitude. I mean, this is not a policy issue. This is an issue, people's issues. Men have to participate in household chores and childcare. The entire burden lies with the women. So childcare, women's ability to work in the workplace are not just women's issues. They are as much men's issues, they're societal issues. And finally, India's demographic transition presents both challenges and opportunities. By prioritizing healthcare, gender equality, education, the country can harness its demographic dividend and ensure sustainable development. In fact, we are assuming we'll always have this window of opportunity because we have a young population. Other countries flourish. But you have to invest in people. You have to support with skilling. It will not happen automatically. So this budget also disappointed me from the point of skilling. Yes, there was talk, there is investments in technology for young people and so on. But we need to work on mission mode, as Dr. Urvashi Prasad also said in her earlier statement, and incremental investments in human capital cannot be the way forward if we want to Viksit Bharat and we want a healthy population in India, which we all do, and I assume and accept and trust the government does, and all of us do. So overall, we have to understand the demographics. There is more myths and misconceptions in spite of having very good demographic data. And finally, I'll end with the two chief ministers who have to worry about aging, who have to worry about the exercise, the delimitation exercise, and not divert it and put the burden on women as though they are a switch you can put on and off to have children. Frankly, it's not even connected. If you have an aging population, if you have a delimitation exercise, deal with it. Don't go automatically to burdening women. And I'll end there.
Thank you so much, Poonam. You have addressed all the issues so pertinently, addressing the regional fertility disparities. I was just noting down the way quickly you were, and I tried to sort of put down all the points. You rightly said that India's population is projected to peak at 1.63 billion by 2048 before declining. We need to have differential policy approach. Investing, you emphasize on investing in women's skilling, integrating the migrant workers, which is also very much essential because we are going to have urbanization, growing urbanization in future years. So integrating migrant workers is very essential. Expanding services in lagging states, especially also you spoke about the strategy. Family planning strategies must be region specific. The way you gave the example of UP leveraging their how they have leveraged their women and how we can actually leverage the young workforce for economic growth while preparing for the demographic shift. Empowering women, you spoke about the investing in gender, geriatric health. You spoke about work for women labor participation. You spoke a bit about the social, gender equity and address the care economy, I think, and addressing the societal issues, harnessing the demographic dividend. I think all this really needs to be addressed. And you also spoke about the recent remarks of Stalin and Chandrababu Naidu, and you very rightly mentioned that it is as if that the political leaders, not only in India but across the world, they are entering the bedrooms and telling women like what they have to do and what they don't have to do. Thank you so much, Poonam, for raising all these pertinent issues. Now I am coming to, I think that Dr. Sitaram has come. Dr. M.R. Sitaram, SBYM and Senior Orthopedic Consultant. Sir, now I think that doctor has been very busy and he had requested that he would be last to speak. So over to you, sir, now. The stage is there for you. We would like to know about the budget utilization since you had actually, we would like to know more from you about the convergence strategies, how the funds are reaching the ground, how different ministries have to converge to get the better dividend of the whatever the budget allocations we have. And I would like you to also address the medical workforce readiness. Can India train enough doctors, and quality versus quantity, if you can address that thing? And also, if you can talk about a bit on affordability, accessibility, because since you are working very closely with the youths, so I would like you to give a different perspective, like what is our demographic dividend, the adolescents, the young adults, what is their challenges, and how we can actually make India do larger good for our populations. Over to you, Dr. Sitaram. Am I audible, sir? तनु, डॉक्टर सीताराम जी हैं क्या, आए हैं?
Yes, ma'am. I think he's facing some connection issues.
Yeah, but it seems stuck.
Good evening, sir. Over to you.
Can you hear me now?
Yeah,
We
yeah.
can hear
Yes,
you.
sir.
Yeah, I did hear you. I hope, I have been having challenges connecting and initially, and now that I'm connected, I hope I stay connected. Hope I'm audible. And
You're audible, sir.
if
Please
so,
sir, if you want to break it up into two different things, like you would like to address, the adolescent and youth and the workforce issue first, and then you would like to come to the affordability and converting. It's entirely up to you the way you would like to take it. Over to you, sir.
yeah. So I and how that sort of trickles down to the end user. I think initially also it was mentioned that budget is a nice statement of intent, nice intention, well made out. It's not much of use at all. Good intentions are nice to hear, but they don't create impacts unless they are utilized. So I'll take a more broader development perspective, going beyond just issues around what was presented yesterday. So looking at the budget and the plan itself, I see there are two components to it. One is that has to be appropriate allocation. To make that happen, there has to be a budgetary allocation as well. So there are two components, and there has to be sanctity to both the allocation and to the intention. Now, only when these two are respected, we will see the good end result. generally, as we see as development workers, what we see across the board in different departments, different development processes, is that there is a tendency to focus more on the allocation itself, because that is more seen, more visible. Let's say there is a allocation for capital investment of X crores. The king of X crores, whether spent or not, becomes very easy. Whereas the intention behind that health of the general community, what is generally tracked and reported and seen as utilized is just this money part of it, the allocation part of it, and we don't look at the intention, whether that has been actually fulfilled at all. So I think when we talk of actual utilization, we have to look at the allocation part, whether whatever it is for the said intention, and the fulfillment of the intention itself. So from this point of view, for enhancing the utilization, I think there are certain key steps that we need to strengthen. What we see generally is that there are general, well-known hurdles and roadblocks, if you may. One such thing is to keep quiet till the end of the year or end of the reporting period. And just as we reach January, February, or March, go into a hyper spending mode and say that, okay, by end of March, we have utilized the whole thing. But that doesn't serve the purpose. It doesn't really translate the intention for which that money was actually allocated into actual impact. So we need to have a mechanism which would better ensure a spread of this sort of spending over the entire 12-month period. Make sure that regional contexts and expected seasonalities are taken into account when we plan it. So converting this budget, which mainly talks about money, into actionable plans at the grassroots is very important. Now, the union budget has come up with a very gets utilized, it has to trickle down to the next and the next level. So this has to be released to the states, and then the states have to then make sure that their contribution is, and then it has to trickle down to the district level where it's actually utilized. So there are these steps, there are these bottlenecks, if you may, which need to be eased out. Right now, we do have a really good mechanism which is being put in place for periodic reviews, midterm reviews, monitoring and evaluations, but that needs to be streamlined and strengthened so that, there is a mechanism to red flag the non-starters, slow runners, so that there can be appropriate pushes, there can be appropriate mechanisms to overcome and help out the budget utilization part, and make sure that the intention for which it was actually meant is actually realized at the end of the year. So this calls for good governance across the board, transparency, disclosures, etc., and decentralization. That sort of brings me to the point that I feel is very important. Health, as we all know, is a multifactorial, multidimensional state, not just one absence of a disease, as we often call it. So for the health of health, we also need this sort of collaboration. We have to make it channel. Now, that calls for intersectorality, interministerial collaboration, and that is something that I feel, again, as a beyond of health and health department and health ministry, and in some way linking up to your next question of youth and adolescents, there is a lot intersectoral approaches can give a much bigger bang for the buck. The health is actually determined by the health determinants, not environment, nutrition, these dimensions that are not directly under the Ministry of Health need to be harnessed, need to be galvanized to make sure that health is achieved. And there are a lot of room for that sort of collaboration. Swachh Bharat Mission, for instance, has on paper a good opportunity for convergence there. But I, being a very active WASH warrior at the convergence. Similarly, Jal Jeevan Mission, there have been excellent allocations and excellent intentions of both these great missions. But if these two can actually make things happen, make sanitation a reality, and if water, potable drinking water, really flows through the pipes that have been laid under Jal Jeevan Mission, then achieving health for all will become far easier. And by there's a care to tertiary care in this budget. Yes, I agree. But if parallelly we can work in tandem with allocations that already exist elsewhere, I think there can be a much bigger bang for buck. And we need to explore on that sort of collaborative approaches to make sure that both the health intentions are met and the department's intentions are also met under Jal Jeevan Mission and Swachh Bharat Mission. I feel the youth that you mentioned, the group that I also closely work with, can be a great game changer. They can make or mar any nation, any society for that matter, and they can also be, they are highly vulnerable. Adolescents and young adults, youth, they face a lot of vulnerabilities, especially in today's. They're already at risk, and unless their power, their energies are channelized into positive nation building activities, we will definitely have a much greater problem on hand. Now, let's take the issue of addictions, which again, struggling to come out of these addictions. The first use always occurs at adolescents or as young adults. And if the health department can actually work in strong collaboration with the Ministry of Youth Services and the departments of and the we can collaborate and converge efforts. They would have some budgets as well, and the health department would have its budget. So if these two budgets can be actually converged, there can be definitely far greater impact. And youth can actually be harnessed. I have worked with the NSS, the NCC, and in terms of behavioral change communication. They can themselves develop a strong momentum to positive health from a more dependent on alcohol. But there are new demons emerging, the device addictions, the social media, which are creating havoc in multiple ways, adding on to the unseen burden of emotional health, mental health challenges, and leading on to a lot of unrest in the society in general. So I feel that for a win-win, we need to look at a strong convergent approaches across ministries and across departments, and see if we can have a proactive mechanism to nurture and develop these partnerships down the line. If it can start from the center down to the state, well worded in our policies, we see that at the level of action, there is not enough focus, not enough force that is transmitted to actual action. So I feel that to ensure proper budget utilization, this sort of transparent approaches, a good action plan to make sure that the intention as well as allocation both are sanctified by proper leverage funds from associated and related ministries for a set purpose will go a long way in enhancing our intended impacts. Yeah.
Thank you so much, Doctor. Thanks. Even though like your this connectivity was not that much, but we could get and we could grasp what you meant. You spoke definitely about the convergence issues by sort of like having the both intra and interconnect convergence within different ministries, and you addressed the youth, the demographic dividend. You spoke about the robust governance, having the proper mechanism of implementation, then definitely having the supervisions on ground, joint missions, and how we can achieve the larger good for our health, our overall good of our citizens. Now I think over to you, Preet. I think if there are some questions from the audience, we can take them up. And later on, closing comments, we would like to take some closing remarks of maybe for 1 minute or so. Maybe our panelists would like to throw a couple of bit of ideas before I will give my closing comments. But prior to that, if there are some questions you would like to take up, over to you, Preet.
Okay, so now the floor is open for the questions. The participants can kindly unmute themselves and ask the questions. Okay, so sir, I have one question from you, Uplab sir. Sir, you mentioned about the missing middle, like the people who belong to the upper quintile and the lower quintile, they are covered by insurance companies, either by private or the government schemes. So, like, how can we tackle this? Should we continue spending more on the lower quintile people, or how can we cover the missing middle people, the upper middle class, and the middle class people? Can you please throw some light on this?
Yeah. Hello, am I audible?
Yes, sir.
Hello.
Yes, sir, you're audible.
Yeah, just please give me a
Dr. Gopal, you're audible. Please continue.
Yeah, I think partnering up with health insurance would be like like something like a health insurance product for the missing middle class would be amazing, in my opinion. And how do you say? What is the word? I think this missing middle word comes from the Niti Aayog report that talks about people who who are not under cover of any government program or also not really poor. So like they don't qualify for government schemes like Ayushman Bharat, or nor are they like wealthy enough to afford private insurance. So like this includes middle class families, you have gig workers like Zomato, Swiggy drivers, you have informal sector employees, uh, you have lower middle income households, like many of whom who are just like one medical emergency away from financial distress. I think this is called catastrophic healthcare spending. So like should we prioritize government spending on the poor and let the missing middle like find their own way? I don't think so, not necessarily. The real issue is how we allocate resources to create a more inclusive and sustainable system. So I think the missing middle, I think, matters because they lack financial protection. Like unlike the ultra poor who benefit from fully government funded insurance schemes, the missing middle is excluded from major public health insurance, and they have to rely on out-of-pocket expenditure or out-of-pocket spending, so which still remains nearly high, around 40% in India. And I think the missing middle drives the economy. So like they include taxpayers, they have small business owners, they have informal workers, so like whose productivity directly impacts India's economic growth. Like keeping them financially secure in health crises like reduces the long-term economic shock to our country. Like a health shock is something that can push a middle income family below the poverty line, like medical emergency away. So creating a vicious cycle, like where families like have to sell their assets or have to take loans just to afford treatment. Health security must be universal to prevent long-term economic setbacks. So how can we tackle this problem? Like we can expand the insurance coverage to just like beyond just the poor. So like for example, what would I would have liked to see on the budget would have been a reduction in GST for health insurance premiums from 18% to 5% to make the private insurance more affordable, and like create a contributory public-private model, like insurance model, where middle income families can pay smaller premiums, but they can still receive coverage. I think we can also leverage PP for affordable healthcare, like encourage the private sector hospitals to offer subsidized rates for essential services, like in exchange for government incentives. We can also build a system like a state-backed micro health insurance models for gig workers. I think in the recent budget for gig workers, 1 crore gig workers insurance Swanidhi was announced. I think that is a good step in this direction. And like strengthening primary healthcare can help reduce the costly hospitalization. So like investing in preventive care, PHCs, diagnostics, it can help reduce the need for expensive tertiary care. I think telemedicine also is an upcomer for the missing middle, which can reduce the dependency of this class on the hospitals. So like spending on, like, should we stop spending on the poor? I don't think so. Like spending on the poorest population is still essential because they face the greatest barriers to healthcare. However, this doesn't mean that the missing middle should be ignored. Instead, like a either or approach, India needs a tiered system, like tier system that ensures like free healthcare for the poor, subsidized government-backed health insurance for the middle class, and like regulated private healthcare for like higher income groups. So like if India wants to achieve UHC or universal health coverage, like the focus should be on balancing the resources, like ensuring that both the poor and the missing middle have like access to quality, affordable healthcare. Like they don't have to face financial hardship. So like the middle missing, I don't think the missing middle is not asking for free healthcare. They're asking for financial protection from catastrophic expenses. So if we continue to ignore them, I think then we risk widening a healthcare inequity and like pushing more families into economic uncertainty. So like a blended model, I think would be something that can close this gap and like create a truly inclusive healthcare system.
Thank you,
Does
Dr.
this
Gopal.
answer your question? Yeah.
Tanu,
Thank you so
does
much,
it
sir,
answer
for
you? Yeah. Are there any more questions for Dr. Urvashi or maybe Dr. Poonam or someone else? If there are, I think quickly you take maybe 1 minute or so, because it has been very good, enriching discussion, but we have to look at the clock as well. So
Yes, ma'am. So, ma'am, the last question is about the Anganwadi workers. Like in urban cities, when we talk about concepts like digital health and digitalization, so we see ASHA workers and Anganwadi workers are the only channels we can penetrate these concepts into the rural India. So, can we talk a little bit about them, that how they play a vital role into this?
question is addressed to whom? Urvashi,
Uh,
Dr. Urvashi or Poonam ji?
Anybody, like if ma'am wants,
Can I just say something regarding this?
Dr. Gopal, very quickly.
Yeah, okay,
Because
just in
both
one
the
line, I think just before the budget came out, a lot of people made really various expectations from the government on what they expected. I think the ASHAs, which are the frontline workers of the community, I think the representative group for the ASHAs made a very big demand of the government that why still treat the ASHAs as volunteers and why not treat them as like as regular health employees, because they're doing a lot. Any new intervention that you think of is dumped on the ASHA's plate. And secondly, the ASHAs have also demanded that their pay structure has not been revised in the last 10 years for like in an open letter to the government before the budget. And I think that was still not addressed in the like budget that was presented? I think Dr. Vashi or Dr. Poonam might be better able to answer this question.
They have incentives only, no pay structure. Over to Dr. Urvashi and Dr. Poonam, to any of you first. Both of you can take it one by one. Dr. Urvashi, you can give it a maybe one-liner.
No, I think let Poonam ji go first. She also has to leave.
So, thank you, Urvashi. I have always been very troubled with how the Ashas have been treated in terms of all the burden, as was mentioned earlier, and they are the only one who are on an incentive basis. I found out during COVID, they were asked to spend full time on COVID and they were going to get 1,000 rupees only per month, which means all the other incentives they would not have got. And that's when we wrote to the health ministry objecting and making a strong case. But nothing happened even during COVID, and our Ashas, they were like our COVID heroes. In fact, I made a 3-minute film on the role they had played, which got millions of hits, and even our then Women and Child Development Minister tweeted that. But this is an anti-gender, anti-women issue, that you treat them like burden of beast, but you do not give them even half of what they deserve. Not that the Anganwadis are much better off. So I think we need to raise this as an issue of indecent pay, overburden and work. And I think all of us need to support the Ashas in getting more. And the bureaucracy, there's a lot of things I can move the needle with the bureaucracy on policy. But the one place they are adamant, they keep saying, when I raise this issue, they say, oh, they'll become like the rest of the workers. They won't work if they become permanent employees or full-time employees. I think this is total discrimination that we really all have to, each of us has to raise our voice and do what we can. But it's a hopeless situation right now. It's not going to be easy, but we have to work on it.
Over to you, Dr. Urvashi Prasad. Maybe you would like to put some more comments on it.
Ma'am, we have one question for Urvashi, ma'am.
Okay.
Ma'am, when it comes to Ayushman Bharat scheme, then there are trust issues between government and the private sector. Can you please throw some light on this?
Poonam ji, do you want to say something? You look like you want to say something.
You're giving me every opportunity. I'll quickly say that there's a total history of lack of trust and lack of faith between the public sector and the private sector. And the public, I am amazed how they view the private sector as taking away their money and not giving services. This has been a problem in every state, even in Gujarat, that very important scheme, Chiranjeevi scheme, where there was it was so well designed. It was fantastic. The maternal mortality, morbidity was coming down. It was for maternal health, a collaboration between the private clinics and government. And I am amazed, even there they refuse to pay. A government babu thinks that the money is his or her money is being taken away. We have to change the mindset and the mentality for public. Now, I'm not saying that's the only problem that we have, which is the lack of trust, but also we don't have any regulation for the private sector. So if we really want a good private-public partnership, there has to be some regulation of the private sector. The poor public sector is fully, controlled and so on, and regulated. We still have problems, but, the lack of regulation in the private sector, and I want to also say to Dr. Uplab, who is very gung-ho and rightly so about medical tourism. But for medical tourism, we need as an essential condition some regulation on the private sector. The only MTP Act, the only act that's regulated in the private sector is the MTP Act. And without the MTP, even with the MTP Act, we have so many problems of sex selection and so many other things. I can't even imagine what would happen to women. So I'm not saying all private sector is bad, but we have to make rules for those who violate the right practices. Thank you, Urvashi. I'm answering for you, but please go ahead.
Over to you. Urvashi, anything you would
No,
like?
I'm glad she made those points. I totally agree. And just very quickly, I would more so endorse, what she's saying. I think Ayushman is also facing a lot of issues because somehow that relationship is not working out, the public and the private. We wanted a lot of private investment to come in, not just into big cities, but also into the tier 2, tier 3. But we've still not seen enough traction on that. And I think, whether it is hospitals having issues of non-payment of dues, I think package rates is a very old dispute, between the public and the private. And, we don't seem to be coming to a consensus and really being able to move ahead with that. So, therefore, then, the PPP just in many cases remains kind of a nice idea, but it's not happening as well as it can. And I think the regulation part is very important because, even healthcare, especially, I would say such a field that even one, bad instance can leave a lasting impact, in the mind of course, the person who suffered, but also in the mind of, everybody else to say that, okay, this place we see malpractice or we see this kind of thing. So I think we need that regulation. We need strong action on wherever things go wrong, whether it's in the public sector, whether it's in the private sector. But private in healthcare is still a great extent informal. It is very small establishments, few beds, small nursing homes. I mean, there's just no way that, we have been able to regulate any of these. And I think that worsens the trust or the mistrust, that is there. Because if you go to one of these nursing homes, you have a really bad experience, you kind of then feel, okay, I can't trust any of these guys. So I think we need to, it is difficult, but we have to address it. I mean, I don't think there's any way around it. So I fully agree with Poonam ji on this.
Tanu, any other question?
No, ma'am, we can proceed.
So now I think that in case there is someone else, like maybe Dr. Sitaram would like to say a bit, like in case he's
Ma'am, his connection dropped. Very weak
okay.
connection. Yeah.
Okay, so I will briefly talk about 1 minute, maybe probably. I agree with Poonam ji and both Urvashi ji when it came to because I could also, recapitulate my experience of working in Chhattisgarh, wherein mission director told me, आप लोगों ने central ministry and others ने तो बिल्कुल तबाह किया है इन आशास को. मितानिन जब हम लोगों का होता था, Mitanin never used to take any money, and now we have made ashas, and they are looking after the incentives and all that. It was never there because Chhattisgarh was a state who had initiated the Mitanin concept, and that is how the asha concept came. So my closing remarks, I would like to first of all thank all of the esteemed panelists, Tanu, Arjun, IMPRI, for giving us this opportunity to talk about health budget. Especially esteemed panelists for an engaging and insightful discussion. While I agree that 11% budget allocation signals intent, but the real challenge is ensuring that healthcare is seen as an investment and not as expenditure, which Dr. Urvashi raised this, question. Incremental increase alone won't bridge the gaps in workforce readiness, infrastructure, and equitable access. The key lies in good governance, strong supervision, ensuring that policies translate into action at the ground level. Cancer care expansion, medical education reforms, AI-driven public health solutions offer immense potential, but without right implementation and collaboration and interministerial collaborations, involvement of the core beneficiaries from the ground, involvement of the patients, I think the execution actually falls short. Budget utilization often peaks in the last quarter, as Dr. Sitaram mentioned, and we have also experienced during the program implementation plans and how they are made, and how at the end of the last quarter, we ensure that at least the funds are finished so that we can again put the requisitions. How do we ensure timely and strategic deployment of the funds? Similarly, while India is expanding its medical seats, what Dr. Uplabh has said, we must ask what is the use of doctors if we cannot retain them. We don't have proper kind of, HR at the last end, at the last mile, serving our people. Addressing ghost faculty, structured faculty pools, and incentivization, retention with India must be a priority. Public-private partnership can be a game changer, but we need structured governance, better oversights, and sustainable models to succeed. Medical value travel or tourism is another critical area. India has expertise, but when it comes to the global competitiveness, people see that what is the quality care in India, what are the hygiene practices. I think that we have to look, it needs patient experience. Definitely it needs accreditations also, as he mentioned about JCI, and also a single window regulatory framework to streamline the process. Finally, on women's health, we spoke about the family planning. We cannot afford to remain reactive. Despite progress in reducing the MMR, access remains deeply unequal. Tribal communities, adolescents, and 57% of the women facing anemia continue to be undeserved. A demographic dividend is only realized when investments are made in women's skilling, young adults, productive health, healthcare, elderly care. I think as we move forward, the focus needs to be on strategic convergence, timely budget execution, robust governance, interministerial collaboration to ensure that India's healthcare system is not just growing, but truly transforming to meet the future demands. The time for fragmented approaches should be end of 25-26. I think we all need to come together. Rather, all the people of India must act with urgency and a vision. These are few of the remarks from my end. And over to you, Tanu.
Thank you so much, ma'am, for your kind words. Now we can take Urvashi, ma'am, for the closing remarks.
Yeah,
if
just
any panelist want to say anything?
I really need to go.
I think let's hear Urvashi ji and Puram ji in case you have to say something, and Uplabdha is also there. But definitely, I think Dr. Sitaram has left, I think. So his connectivity was not that good. Yeah, please continue. Urvashi, if you would like to.
Yeah, just, I mean, I'll just, very, very briefly, just to kind of reiterate a lot of what we've been saying, that it's not an expense that we are making in these areas. We often call them social sectors, which I've always had an issue with because it kind of makes it seem that these are just feel good and slightly softer sectors, but actually, as Poonamji also said, and we discussed that even your economy is actually built on these sectors, and that's really the backbone. And I think until this mindset shift happens, and it's people like us, discussions like us, it's very hard, like Poonamji said, certain things, moving the needle is just so difficult. And I've seen that system very closely and from the inside as well. But I think we just have to keep at it, and we have to keep reiterating some of these things, and really trying to make progress in whatever way we can. We're already doing individually what we can, but I think these messages need to keep going out because the change will take time, but I think it will happen if we have enough of us saying it often enough, that these sectors are not just soft sectors or just social good you're doing. You're also investing in the whole economy, the country, the society, everything. So I think that mindset is all, I would end with and say that if that shift happens, a lot of the other things can, flow from that. Thank you.
Thank you so much, ma'am. Now we'll move forward with the final vote of thanks. So, as we come to the end of today's discussion, I, Tanu Paliwal, researcher at IMPRI, Impact and Policy Research Institute, would like to propose the formal vote of thanks on behalf of IMPRI, Center for Human Dignity and Development. I would like to thank all of you for attending today's deliberation. A panel discussion on population health and Union Budget 2025-26. We are grateful to our chair for the session, Dr. Manorama Bakshi ji, our esteemed panelists, Dr. Urvashi Prasad ji, Dr. Poonam Mutreja ji, Dr. M.R. Sitaram ji, Dr. K.S. Uplabh Gopal ji, for taking part in the discussion and enlightening us. We thank all of our participants who have raised pertinent questions and actively participated in today's deliberation. We are grateful if you are watching us later on our YouTube channel or listening to us on our various podcasts or reading our publications. We look forward to welcoming you for the day 5 of our budget deliberations tomorrow, that is February 5th at 3 p.m. for Rural Realities and Union Budget 2025-26, followed by Cities Local Governance and Union Budget 2025-26 at 6:30 p.m. tomorrow. You may also find more thematic events and book discussions under IMPRI Web Policy Talk series. We hope you continue to join us in future to our IMPRI Web Policy Talk and Web Policy Learning. Wishing you all a very good evening and thank you.
Thank you so much.